Good morning, everyone. My name is Hervin Heeroo. I'm one of the ENT registrars at UCT. So this morning, I'll be presenting on medialization laryngoplasty for unilateral vocal cord paralysis, but I'll be focusing more on aspiration. Consent was obtained from my patient to present the case, and all my content is referenced. So the case I'm going to present is of a 53-year-old male who was 1 year post bilateral lung transplant. He had a left unilateral vocal cord paralysis with decreased laryngeal sensation. He had a high-pitched voice, and he was aspirating on both liquids and solids, and he was on strict PEG feeds. We did a successful injection laryngoplasty with ProLarin. Left vocal cord adduction improved, and the PEG was removed. Unfortunately, he started aspirating again 6 months later. A nasogastric tube was inserted, and we booked him for a left medialization thyroplasty. So we carved a silicone block, cut out a thyroplasty window, and used the implant, the carved implant, to achieve vocal cord medialization. He had an uneventful recovery post-op. He was able to feed orally, and he was not aspirating. The nasogastric tube was removed, and his voice pitch improved. So this is the patient on review 7 months post-op. And as you can appreciate, complete glottic closure on adduction was achieved. The patient was feeding orally on liquids and solids with no choking or aspiration. And his voice has also improved. Almost 100% of Ashesi University. So now I will present on medialization laryngoplasty for unilateral vocal cord paralysis with a focus on its role in the prevention of aspiration. So we know that vocal fold abduction and adduction are critical components of airway protection from food, fluids, and secretions through effective mid-swallow airway closure and reflexive cough response. A 2018 retrospective observational study from the University of Auckland in New Zealand of 106 patients who needed a flexible endoscopic evaluation of swallowing following cardiothoracic surgery showed that the study participants who had an age range of 18 to 87 years, a mean of 63 years, and with a standard deviation of 15 years, 64% of the patients had vocal cord paralysis, and vocal cord motion impairment was significantly associated with ventilation time and tracheostomy tube duration. As you can see, the p-value is less than 0.05. Unilateral vocal cord paralysis occurs from the dysfunction or injury to the recurrent laryngeal nerve or its originating nerve, the vagus nerve. The nerve injury can produce glottal incompetence, weakened cough reflex, and laryngopharyngeal sensory dysfunction. These patients are at increased risk for penetration and aspiration events. Impaired vocal fold mobility can cause symptoms of dysphonia, dyspnea, decreased cough strength, and dysphagia. Aspiration reportedly occurs in 23 to 53% of patients with unilateral vocal cord paralysis. Vocal cord motion abnormality has been identified as an independent risk factor for pneumonia development. The graph that you can see on the screen demonstrates the results of a 2018 nationwide study performed in Taiwan, comparing patients with unilateral vocal cord paralysis to age-matched controls. It noted that patients with unilateral vocal cord paralysis were significantly more likely to have aspiration pneumonia than those without vocal cord motion abnormalities. Vocal fold paresis or paralysis after thoracic procedures such as pneumonectomy, lobectomy, and mediastinoscopy has an incidence of 6 to 31%. In fact, in 2018, Faudrain et al. Examined a cohort of 250 patients in France who were intubated with a double lumen tube for pulmonary resection and lymph node dissection. Post-operatively, 5.2% of the cohort developed unilateral vocal cord paralysis. Aspiration was diagnosed in 7.2% and significantly associated with an increased rate of post-operative pneumonia, as well as increased 90-day mortality. The authors suggested that vocal fold medialization early in the post-operative course when unilateral vocal cord paralysis is initially noted. The goal of any treatment of unilateral vocal cord paralysis is to improve glottal closure, either by changing the vocal fold position and volume or by activating the paralyzed vocal fold. Several surgical procedures are available, including intracaudal injection, type 1 thyroplasty, arytenoid adduction, laryngeal renervation, and combinations thereof. And despite the fact that speech therapy is a common treatment for patients with unilateral vocal cord paralysis, there is limited evidence regarding the effectiveness. Classical management of unilateral vocal cord paralysis advocates a waiting period of up to 12 months for spontaneous recovery before invasive surgery is considered. During this waiting period, the two management options are surveillance with or without voice therapy or vocal cord medialization by injection or type 1 thyroplasty. Local cord injection has become a major treatment option for the acute onset post-operatively of unilateral vocal cord paralysis because of its effectiveness, non-invasiveness, and low rate of complications. Moreover, the procedure does not interfere with physiologic renervation and can be repeated if necessary. Intracaudal injection can be performed percutaneously in the awake patient. The advantage is that one can hear the patient's voice while still being able to visualize the position of the vocal cord. Early medialization of the paralyzed vocal fold, either by vocal cord injection augmentation or type 1 thyroplasty, reduces aspiration and improves cough ability in patients who are diagnosed with a new onset unilateral vocal cord paralysis after thoracic surgery. A retrospective study of 86 patients by Bhattacharya from the United States showed significantly less pulmonary infections if vocal fold medialization was performed in the first 4 days post-thoracic procedure compared to medialization performed after this. Moreover, a 5-year review by Chen et al. Of 35 patients who underwent inpatient injection laryngoplasty following aortic repair showed that intracaudal injection in the first 5 days of the extubation was associated with a significantly shorter hospital length of stay. It was 13 versus about 20 days. According to a systematic review and meta-analysis by Villa in 2018, patients with unilateral vocal cord paralysis who do not receive early intracaudal injection are 4 times more likely to undergo thyroplasty in the future. And as you can appreciate from the forest plot of 4 studies, the overall pooled relative risk of undergoing thyroplasty in those who received an early injection laryngoplasty was 0.25. Early injection was defined as being performed within 6 months from diagnosis. The studies were performed in various locations, including Canada, Taiwan, and the United States. A little bit of history. So Wilhelm Brunings first experimented with restoring glottic insufficiency by injecting paraffin into the vocal cord in 1911 in a patient with presumed recurrent laryngeal nerve paralysis. He managed to achieve satisfactory approximation of the chords during phonation, and hence giving back the patient his voice. However, the technique is no longer in use due to its side effect of forming granuloma. Then in 1915, Edwin Parr performed the first laryngeal framework surgery on a soldier who could not speak after a hemithyroidectomy surgery. He created a trap door on the thyroid cartilage, which pushed the vocal cord medially and restored the patient's voice. However, the actual medialization was limited and restricted the technique's utility. And decades later, in the 1950s, Ergo Merman and Oppheim both revived the idea of medializing the vocal cord by using various cartilage grafts inserted between the thyroid cartilage and the inner perichondrium to establish vocal cord medialization. They demonstrated improved voice quality with their surgical procedures. However, they faced severe post-procedural edema and hematoma formation, hence requiring tracheostomy. Then Japanese laryngologist Nobuhiko Ishiki described the famed and eponymous 4 types of thyroplasty in 1974, of which type 1 is the medialization procedure using synthetic implants. Type 2 is the lateralization procedure. Type 3 is the shortening of vocal cords to reduce the pitch. And type 4 is lengthening to elevate the pitch. The goal of the medialization thyroplasty procedure is to modify both the position and tension of the vocal fold to restore glottic closure. In practice, anyone presenting with glottic incompetence that results in poor phonation and/or a weak cough can be considered a candidate for medialization laryngoplasty. It has been demonstrated to improve rehabilitation in patients with high vagal nerve injuries by restoring glottal competence, thereby potentially reducing gross aspiration and improving the voice quality in the setting of a high vagal nerve paralysis. Immediate and delayed complications from medialization laryngoplasty, although quite uncommon, can occur due to several causes. Airway edema, hematoma, and prosthesis extrusion have all been reported in low numbers. The rates of complications from these procedures were noted to be inversely proportional to a surgeon's individual experience with these surgeries. Revision rates in medialization laryngoplasty were also quoted to be quite low and demonstrated a 90% likelihood to result in improved patient-perceived voice outcome. Patients seeking revision thyroplasty commonly complain of dysphagia, dysphonia, or dyspnea. The most common causes for early failed medialization were arytenoid malrotation, resulting in a persistent posterior glottic gap, and incorrect implant position and size, failing to result in adequate vocal fold medialization. Delayed failures of medialization thyroplasty, although less common, are due to subsequent vocal fold atrophy and very rarely a foreign body reaction to the implant. In Ishiki's original paper, examining the outcomes of his type 1 thyroplasty surgeries, he noted that medialization alone did not resolve the difference in the level of between the vocal cords at the level of the vocal process. These limitations drove Ishiki to develop arytenoid adduction procedure, which can be performed either alone or as an adjunct to his type 1 thyroplasty surgery. In combination, the medialization laryngoplasty and arytenoid adduction procedures can provide vocal fold medialization, closure of the posterior commissure, and restoration of symmetric vertical height between both vocal cords. And this allows correct positioning of the arytenoid cartilage and gives tension and bulk to the paralyzed vocal cord. Glottal incompetence caused by unilateral vocal cord paralysis is a common cause of dysphagia and aspiration. 2/3 of patients suffering from unilateral vocal cord paralysis will have dysphagia, and 1/3 to half of these patients show evidence of aspiration. Injection laryngoplasty and medialization thyroplasty are well known to improve voice outcomes, but improvements in swallowing function are less clear. So Dar and al. Did a systematic review in 2022 of 157 patients who had formal swallowing assessments both before and after medialization. And the most common etiology of unilateral vocal cord paralysis was iatrogenic, representing 47% of these patients. 59% of the patients underwent injection augmentation, most commonly using Restylane, which is a form of hyaluronic acid, or they also used autologous fat. The remaining 41% underwent medialization thyroplasty, most commonly with a transcervical silastic implant. The authors found clinically significant improvement in swallowing function in 7 out of 9 studies and concluded that there was moderate evidence to support the use of vocal fold medialization to improve swallowing function in patients with unilateral vocal cord paralysis. In the pediatric population, the main cause of unilateral vocal cord paralysis is trauma resulting from cardiac surgery, specifically patent ductus arteriosus ligation in up to 43%. While there is consistent data for adult vocal fold paralysis regarding rate and recovery time, this is poorly established in the pediatric population. A retrospective study by Jabbar and al. Of 299 children with unilateral vocal cord paralysis after a mean follow-up of 17.2 months reported that 28% recovered movement, and in 56.9% symptoms improved. Thus, almost half of the patients remained symptomatic. Recovery was reported as late as 30 months after the injury. The wait-and-see strategy may be used if there is good compensation for glottic function. However, in symptomatic and smaller children, this may prove problematic. Aspiration may lead to recurrent respiratory infections and the need to change the consistency or the route of administration of the diet. And when a significant glottic insufficiency is present, early surgical intervention for glottic closure is strongly recommended. Several therapeutic options are available for managing aspiration or dysphonia secondary to unilateral vocal cord paralysis, and that includes speech therapy, injection laryngoplasty, type 1 thyroplasty, and laryngeal reinnervation. And when choosing the procedure, the following should be considered. So we need a window of possibility for spontaneous recovery, the need for immediate effect, potentially compromised airway, and the consent of the parents to form a new external skull. Thyroplasty is the least used surgical strategy in pediatric patients. The limitations for performing it on the pediatric population include, firstly, it is impossible to perform under local anesthesia. It has unpredictable long-term implant duration, decreased implant retention capacity caused by less calcified infantile cartilage, and lastly, a change in the implant position and the possibility of revision surgery due to laryngeal growth. In children, injection laryngoplasty is usually performed under general anesthesia. The results for voice and aspiration are immediate, but this is transitory due to the resorption of the material requiring multiple procedures. And there is little information on the optimal timing of injection laryngoplasty in the pediatric population. In a systematic review and meta-analysis by Heeroo and al. Published in 2021, 11 studies were used to assess 130 patients with a mean age of 6.6 years submitted to injection laryngoplasty under general anesthesia. And the mean follow-up period was 11.4 months, with a range of 1 to 72 months. Isolated aspiration was noted to be the main indication for injection laryngoplasty in 54.5% of cases, and prolarin, which is carboxymethyl cellulose gel, was the most used material in 42.6% of cases for injections. Only five studies cited the dose applied to the paralyzed vocal cord, varying from 0.1 milliliters, especially in kids under 6 months, to 1 milliliters. And 15 complications were reported with an incidence of 11.5%, with stridor being the most common in 4.6% of cases. Renervation of the ansa cervicalis to the recurrent laryngeal nerve has emerged as a quite increasingly popular effective treatment option for the pediatric population. And the goal of renervation is not to recover mobility, but rather to provide bulk and tone to the denervated vocal cord, enabling complete glottic closure by the contralateral vocal cord. It has a low potential for complications. There's the non-use of foreign material and the preservation of vocal cord structure and laryngeal framework for future procedures. A high rate of glottic closure, as high as 95%, has been reported. However, this may be technically a challenging procedure that requires external scarring and entails quite a few months to improve symptoms. In a systematic review and meta-analysis by Heeroo and al. Published in 2021, that compared swallowing and aspiration improvement post-injection laryngoplasty and renervation, the objective parameters for defining improvement in aspiration were decannulation of patients who were previously tracheostomized because of aspiration, the absence of aspiration as assessed by a FEES or a modified barium swallow, in which there was aspiration before surgery, used a decrease in consistency in the usual diet by at least 50%. 84.5% and 91.6% of patients improved post-injection laryngoplasty and renervation, respectively. So, in conclusion, the procedure depends on the patient's preference and expectations, laryngoscopy findings, the cost of the procedure, the start and duration of the therapeutic effect, the surgeon's preference and skills available at the institution. Those are essential components for determining the best intervention for a patient with unilateral vocal cord paralysis in terms of swallowing optimization and prevention of aspiration. So these are the references I used for my presentation. Thank you.
Thank you very much, Hervin. That was a brilliant presentation. Any comments and addition from the floor?
Ask a question. Just the sometimes we get asked this for adult patients, but
we actually presented an adult.
Yeah, sorry, I'm not so.
No, it's fine. The actually is
at the end. Yeah,
I was gonna say.
So the tracheostomy for aspiration. I mean, I thought the tracheostomy wasn't very effective in completely preventing aspiration because you, even with a cup, there's always some. What do you do in the pediatric population?
We try to avoid the tracheostomy and we do a PEG.
Yes.
And we try and reduce secretions.
Okay, and how do you reduce the secretions?
So one of the ways is to do an ISIN if it's reflux related.
Okay.
And then to reduce the saliva.
Yeah. You give them
atropine drops, so Botox, diversion. Basically reducing the volume.
Yeah.
And we actually give them a home suction device if they don't have their own control. And then we could do a slightly gland excision if need be. We just don't want to give them caries, so there's a sort of like weight. But the tracheostomy is for patients who have poor tone and who frankly aspirate and who need complete support, like a stroke patient, that aspiration, not just volume. So those people need a tracheal toilet. So there's the volume. So not only are they not able to clear cough, but they need suction. So patients who have poor cough reflex, that's where the tracheostomy comes into play. Because they actually can't clear and they'll obstruct from a bolus. And so they can go down and get suctioned and they have a cough tube. It's the SMAs, the patients who have poor cough, if they're born with a hypoxic insult that renders them unable to cough, or syndromic kids, where they basically like those mitochondrial diseases and things like that, where they actually can't cough. And they sit there like almost drowning in their secretions. So those are the kids where you can rather let them go down and suction them here, because at least you'll hear the blocked trachea. That's where we do it. But for the bilateral vocal cord palsies, the unilaterals that aspirate rarely need a trachea. Those kids, we do more for them for aspiration before we do a trachea. Unless, and there's only one type, and it's the caustic ingestions. Because the texture and the fibrosis is so unpredictable, even if they have mobile cords, they can still aspirate. So it's because they've lost their physiology from in as much as their anatomy is distorted, they can't swallow. So those kids get their tracheas like Caleb Dexter. But I was interested to ask how many, and I actually wanted to ask you, how many have you guys done? Because it's actually, we should ask Tim Pennell to review all of his transplants and see how many vocal cord palsies there are. Because I remember Esty used to do something in as well.
The prolaren.
Prolaren and Thyroplasty.
Yeah.
It would be really interesting because you quoted something, Hervin, you said if people don't get a medialization procedure early on, 4 times more likely to get a thyroplasty.
Yes.
So I mean, 6 months, even for us, I mean, that's a bit, not early, but early, 6 months. You kind of say, okay, wait 13 months. I don't know what you guys do, but 6 months is quite early to say, okay, let's put a laryngeal. Financially, that may be a bit difficult. I think it's about, what, 12,000?
Yes.
Yeah, so you're gonna like wear a silicone, you know. So firstly, very good talk. I like you, very comprehensive. I just find that the background was a little bit distracting. So I personally wouldn't put that transparent background watermark because I can't read past it if you don't mind. But I think it was really good. I really like your approach. And Nick Volter and then study with Roger and us was really good that you included it. Karen Zohr started all of this. And when we ask patients if they want to have animation just for cord strength, nobody wants their neck to be open. They're just so relieved they have the cardiac surgery, they don't care anymore. So we don't really have any patients, even in private. We've had 2 that came to us, but they both don't want to open their neck. It's just something they just feel we're coping. And then the ones that are really bad are ones that needed a cordotomy because they. So I think one of the things to make note of is for aspiration, it's usually paramedian, isn't it? And if you've got a level discrepancy, how do you accommodate for that? your vocal cord medialization.
Yeah.
I don't know if there's a level, because we sometimes see that it's paramedian, but it's also lower or higher.
Yes.
I don't know in adults if they come.
I haven't seen that in adults. We haven't had that many patients come through. We used to have a lot more. Something's changed, obviously.
Okay.
Because we used to see a lot more. Am I right?
Do you think it's maybe the speech therapist?
That's
Able to
able
manage.
They can get injection
The voice clinics, you know, about 5, 6 years ago, we used to see a lot more. They've changed something.
So something's
Changed.
Probably, Hervin, it's worth asking Matthew whether it's an idea to ask Timpeno, because we've got an isolated cohort of transplant patients. Because a lot of things, they audit everything in that department. We've got all of their data.
I also think for the thyroids, I think they're now monitoring, they do lateral nerve monitoring.
Do they do the one around the?
Yeah, so you see, because they do that, it's quite expensive, but we're not seeing half the amount.
That's amazing, especially we don't have comparison.
So since they started doing that because that changed in thyroids, I don't know about the other, but we don't get referrals from him saying they're going to seek this vocal cord because
They're coping.
They're
monitoring.
Yeah.
So preventative and maybe
Yes.
avoided.
Yeah.
There's anybody else want to ask anything?
Isaiah, can I comment quickly? I have to go.
Is he connected?
Yeah.
Well done, Matt. That's a good outcome.
So I don't think we're necessarily seeing less. I think we're just doing more under local in the OPD than was done before in the voice clinic. So most of them aren't actually needing to get to theatre. And the other limiting factors, obviously, are theatre time at the moment. But yeah, I just wanted to say thanks to Hervin for a fantastic presentation. I think I asked him to give this presentation because the outcomes in terms of voice are quite clear for the medialization procedures, but less clear in terms of dysphagia and aspiration. And I think he answered that quite well. So thanks, Hervin. And yeah, that's all I have to say.
Are you collecting your data, Matthew?
Well, we don't really have the case numbers right now, but
Well, how many have you done? 10?
thyroplasties or medializations.
All of it.
Done less than 10 thyroplasties. I'm not sure how many medializations, probably double the amount, probably close to 20.
Good. Yeah, but Mac, are they coming direct? The ones that, so they used to refer them to ENT OPD for assessment of vocal cords. So are they coming directly to the voice clinic now?
Or to you?
They do often come directly to the voice clinic via the speech therapist.
Okay, that's probably why we're not seeing.
Well, that's
And then
great.
the other issue is why we're not seeing so many of the cardiac patients is often we try do them under local because of their comorbidities and their high anesthetic risk, like this patient.
So this was under local?
Well, the thyroplasties we predominantly do where we can, unless there's significant kind of patient factors from I suppose, a psychological context. But most of the thyroplasties, you want to do them awake anyway, because that's how we monitor response and size the implant at the time of surgery.
And so I had a question about the implant and immunosuppressive therapy, because all these patients have a lung transplant, right?
Yeah.
So they would be on lifelong immunosuppressive therapy. Is that a risk for having one of these silicone things in them? Is that a risk at all?
I don't know, unfortunately.
But you haven't had any negative.
We haven't, and yeah, I mean, this gentleman who's, I think, only what guys had a lung transplant, who's had a thyroplasty.
So
he's close to a year down the line now and hasn't had any issues.
Okay, well, that for me, it actually is quite nice. And then the other thing that you had listed, Hervin, was 47% is surgical. What about the 53? So all of post-cardiac or post, so what is the cause of the unilaterals in the non-47%?
Prof, the remaining were quoted to be non-iatrogenic. So basically,
So you a little bit more? Where you looked at one of those studies that a little bit forward. Sure. It was 47% and that was the surgical percentage. So if that was the case, how come, what was that? What was the other 53?
Oh, they were from
That's the
various
case for
schools.
post-surgical cardiac. That's why they don't refer to us because it's not a majority. It's supposed to be 20% in children. If you go, is there not another study that you quote from cardiac surgery?
From what I read, Prof, the remaining portion were from trauma or were idiopathic.
Idiopathic, okay. I suppose idiopathic, you wouldn't rush to do something, it comes back.
And I think, I stand corrected, Matt, you can help me here, but the trauma ones, are you doing your trauma ones, or are you doing them post iatrogenic complication from somewhere else? Because
well, that's what I mean, like,
you know what I mean?
What's the etiology? Is it all
Iatrogenic, yeah.
But iatrogenic
trauma
was
ones are
surgical. But cardiac surgery or
We have had a few.
yeah, so it's okay. All right. All right.
Can I ask a question?
Yeah.
Yes, go ahead.
For the idiopathic ones, is it before you do a thyroplasty, should you routinely do nerve conductive studies, or is that actually not necessary?
We have nerve conductive studies here first.
Neurology can do it.
Yeah, so they do monitor the nerves for thyroid surgery. Like the same like neurosurgery monitors nerves for the skull those things. That it's very expensive. I think per case.
Specifically the idiopathic ones, where we don't find a cause. Do you do nerve conductive studies to see if there will be regeneration? Does it affect your timing of doing a thyroplasty?
So you're saying if there is activity to wait versus if there's no activity you can proceed. I mean something like that. All the time.
Exactly. Precisely.
We've never managed to get nerve conduction studies from neurology.
I think as a thing, we've never really. Matthew, have you looked into that?
Yeah, Vincent, we've never managed to. I mean, I've stopped sending the facial nerve things because it was just because it's like, post trauma, it's like they can come in 3 weeks. Like, okay, well then I don't need it. It's not going to be useful.
I guess one of the things is that was quoted here, Vincent, is that there's atrophy if you wait too long. So I wonder if there is a defining period without conduction studies, whether Hervin, you're the one who's most read now. If you don't do nerve conduction studies in an idiopathic unilateral vocal cord palsy, how long would someone wait to intervene? Hervin?
Yes, Prof. Unfortunately, I have not come across those figures, but I'll have to look into it.
Okay. It might be worth looking at if they all come into the void, because I can tell you now, we used to see them in the clinic.
Yeah. We used to see
idiopathic, we used to see actually in our OPD. So if they come in directly to the voice clinic, then you should have all the data in terms of might be a nice image for someone.
Well, that's what I'm thinking.
You know what I mean? Like, what are those
what's listening with Are we auditing all this?
Chronology.
So then is there being sent as speech therapy in ICU, speech therapy was clinic, and then we only see them when
Speech therapy, but it keeps in the job.
Can you connect with them by email and just connect me? Then I'll ask.
Sure, but that's what I'm saying.
So Shabina is the most read right now, and Shabina says 1 year.
So the thing is, if it's more than 90% nerve degeneration, then it's an indication.
But we won't know nerve degeneration unless we see atrophy, which is too late, I would think. Does that get poor studies?
Although the perspective is like if it's more than 90% and then 12 months with the EMG studies, then
so I would say then, Vincent, the only contraindication for the idiopathic in terms of intervening after 1 year is if it's something relapsing and there's this underlying systemic cause for it. So if you've got an underlying relapsing condition that gives you like an irregular vocal cord mobility, then But if it's idiopathic and it's 1 year and there's no cause defined, you could probably.
Yeah, so I had an interesting case this week, but it's a little bit different. It's a patient that had Guillain-Barré with bilateral vocal cord palsy, and fortunately in the paramedian position, but he's now slowly regaining neurological function. So that's why I'm asking regarding nerve conductive studies. And the timing of intervention, and he's got no atrophy. He's got no atrophy in his cords, and that's a year and more than, I think, 18 months later.
But there's no harm in us checking whether they do studies.
Yeah.
If they do, things are changing. There's a lady called Sonia at Red Cross who did all the studies. We just obviously couldn't get kids to sit still. It wasn't feasible for us. But maybe there is a system here for the idiopathic. Maybe your patient is a worthwhile reason for asking, because bilateral can give you irregular movements.
Yeah, I think it's worse. I remember the one patient specifically where she was booked for a reinnervation procedure on my list.
Oh.
And then I rebooked her. She was from the Eastern Cape, but she was following she was following a thyroidectomy.
Yeah.
And she was 1 year, and then I said, and because the list was overbooked, I was like, okay, let's do it, and let's do it in 6 months' time. When she came back, her nerve function improved.
And that's a venous.
And I was like, oh gosh, we can't do it now. It's actually it's improved, to the point that she did
probably worthwhile me doing just a literature review. But I think we must explore this nerve studies here, see what's out here, and
Because the neurology department is so understaffed and the pressure that they have.
I think it's in private. We can find out what they do in private.
Yeah.
Because we could build it, like we could actually see how much does it cost the patient, how much does it cost.
The problem of conventional reproduction is you need focus on.
Yes, you need to inject
And
to the airway.
so it will depend if they've got the adapters or equipment. I don't know how laryngeal EMG works, but it will depend. Because the probe you use for a conventional nerve conduction study, the two probes, the 2 pointers are visible apart.
Inject in. The thing is, Vincent, it's better to do the nerve conduction studies on a unilateral because you got the normal one on the other side. Sometimes there's so much interference with the bilateral, you're not sure what the movements mean because they inject it. So you need local anesthetic sort of venue. And then you inject it under direct vision. So you could either use like what Divya was doing with the ultrasound, or you could do flexible laryngoscopy and place them.
But you get two complete EMG and then you get nerve conduction studies in a separate.
Yes, but you could see. Yes, but you could see if they can tolerate that EMG. And then you could go ahead and do the other stuff. The problem is I don't know if someone who's got bilateral, you're going to get any nerve conduction studies you can read. Because what are you comparing it to? Unless there's no movement or there's brisk movement. Because you need 2 points to compare these, right?
Do you know one of the neuroelectrophysiologists what does spectrum? No.
Well, there you go. Somebody's volunteered to help.
Yeah.
Okay, we're going to check, Vincent. You've got your own registrar who's looking into it. Thanks. Please fill in your online CPD points, Vincent, and then if you can email it to Farhana, whoever is sitting with you as well. And then at the top of the page, just write Hervin's. Hervin, you must also do one for yourself and for Kate and Aggie. If you can do that, please, as well. The form is on the Red Cross ENT surgery email address. You can do it later. You can go to the end. It's very important that we continuously do this because then it shows that we're here.
And people online?
The people online, if they joined at the beginning, they get the benefit of CPD points. If they're not South African, it's not compulsory on them. So we just need, if there's anybody in the chat who's South African who would like CPD points, they must put it in the chat now before you have some. So you can just put in a chat notice if you wish to have HPCSA payment to the CPD points. Just I think one.
I'm just gonna look at the online thing.
We're only doing it now. Whoever posts it now only now, and then we'll add it here, but if they don't post it now.
They don't post recordings, so you use it.
Yeah.
That's all.
But it's only for people who have.
Shazia, sorry, before I go, I just want to remind Jaco about the student exam at 9:30.
All right, I don't see anyone else with a question on the chat. I think we're gonna wrap up for the day.
Just give them time.
Those who can put up their details for CPD points, you can do that in chat. And we will get your points awarded. Otherwise, thank you everyone for attending. Give it 1 minute for people to type.
Yeah.
Thank you.
Don't edit it, it's on his video off and audio.